Welcome to Headcast, your go-to podcast for all things stroke-related. Here we chat about care, rehabilitation, life after stroke, and the amazing innovations shaping recovery. Whether you're a survivor, a carer, clinician, or just curious, Headcast is where real stories meet expert insights, all with a friendly, down-to-earth vibe. We'll dive into the challenges, celebrate the wins, and even enjoy the occasional off-topic chat to keep things light. So grab a coffee, settle in, and join us on this journey. This is Headcast, connecting hearts, minds, and stories in the world of stroke.
Hi, good morning. Welcome to the Headcast. It's episode 22 on the 2nd of July, and I'm going to be playing a conversation I recorded about a week ago with Diederik Dippel from the Erasmus Medical Centre in the Netherlands. My name's Phil Woodford, your host. Just a bit of an introduction. So I've said on previous episodes that I was going away in June to the Netherlands to cycle, try to raise a little bit of money for Different Strokes charity in England, which is the charity focused on younger working age stroke survivors and providing them with assistance. I'm pleased to say we did that. We raised a few £100s, so I'm chuffed. I know it'll be spent really well by them. So thank you to everyone that supported. Now, unfortunately, my trip was cut short a little bit for two reasons. One, I had a bit of illness while I was over in the Netherlands and needed to get some medical attention to get me over the worst of it. It was nothing too serious, you know. It's one of those things. So I got over the worst of it, but also at the same time, I suffered a mechanical failure with my bike. If you're going to have a problem with your bike, I guess the Netherlands is the place to have it. So I was able to get that fixed, and I spent a week in Rotterdam cycling around on a rental bike instead whilst I tried to recover. So I didn't do as much cycling as I would have liked. But it was a great experience. I loved it. It's a country which I really like. Unfortunately, it did mean that I wasn't able to meet Dave in person at the Erasmus Medical Centre, and we did it over video instead, video conference. So I'm going to play that in a moment, and I hope you enjoy that. Very honest person, which I hope you'll find when you listen or watch the conversation. And there's a snippet at the end where Dave reveals as well some new research, which is around helping young Black women. It's only a small percentage of stroke, but it's a really important percentage. You know, these are people's lives, and it's about how they're looking to prevent these strokes. So I hope you enjoy that, about learning about some of the breakthroughs that are coming through. What did really please me and upset me at the same time, nothing about Diederik, but more about just really learning some more about how they implemented thrombectomy following the trials in the Netherlands. So what you're going to hear in a nutshell is Diederik was one of the principal researchers behind the Mr. Clean trials in 2014-15, which demonstrated that, you know, thrombectomy is the gold standard for ischemic stroke, and it changed treatment across the world. You know, millions of lives upon millions have been affected, you know, either directly or indirectly as a result of this treatment. You'll hear about that. But what I was fascinated about, we still haven't as a country been able to get it consistently rolled out. You know, my area is only a year into being 24/7 with thrombectomy treatment, despite, you know, for the last 4 to 5 years say it's going to go 24/7. And a lot of centres report that they can't because of staffing. You know, they haven't recruited enough people. You know, we have a lot of shortages in this country around specialities. That much is true, but in some areas we don't. And so I was interested, well, how did they do it in the Netherlands? And you'll hear Diederik say, it's not me twisting the words, is that they used existing staff. You know, so there are people out there, what we call interventional clinicians, interventional radiologists, who haven't yet been trained in neuro, in that aspect of the treatment. So that's what they did. They retrained, they used their existing staff. And as he said, this is about saving lives. These people want to do that. So they gave them the opportunity to do it. And that's how they're able to do it right across the country. You know, this is a country admittedly much smaller than the UK, but we've seen this methodology applied throughout Europe and other parts of the world. But for some reason, we still lag behind here. So whilst it's much better than it was, say, a year or 2 years ago in this country for access, it's still not where it should be. And so it was really reassuring. And the reason I guess I got a bit upset inside was that I was told by our hospital that I was being naive. You can't go retrain these people, Phil. It's not that simple. It turned out when I asked them, they'd never even asked their existing staff, would they like to be trained? Would they like the opportunity? And so I assume that across the country, that's what the NHS does. It goes out to its existing staff and says, look, we've got this gap here in provision. If we had the staff, we could save lives and make a real difference here. Would you like to be retrained? Now, I've not met doctors and nurses who don't want to make a difference. So yes, there's a cost to it, but there's a cost to it whether you retrain them or not. There's a cost to people's lives and to the economy, and it goes on and on. So I find it shocking. In fact, I find it unforgivable that it doesn't take place. So I'll stop waffling on now. I hope you enjoy this. Thank you very much. Cheers. Bye now.
I think we got a massive applause when we presented the results in Istanbul at the World Stroke Conference. And I think I found it surprising by itself. And what also surprised me was I can tell that now, when we submitted the paper describing the results and showing that we had 30 to 40% more patients recovering than with medical treatment alone, which is a very huge effect. We submitted the paper in October to the journal, and it was published in January the next year, 3 months. And afterwards, I understood that they waited for the other trials to submit their paper so they could publish 3 or 4 papers about different trials, all showing the effect of the treatment. So that would be very convincing and really changing medical practice in many countries.
Okay, hello. Well, today on the Headcast, I'm really delighted to be joined by Professor Diederik Dippel from the Erasmus Medical Centre in Rotterdam in the Netherlands. Now, Diederik's somebody who's helped reshape modern stroke care, and he led the Mr. Clean trials, the work that proved thrombectomy saves lives and changed treatment worldwide. And we're going to have a go at talking about what's improved, what still needs to happen, and the impact a decade on. Professor Dippel, great to have you with us today, and I hope I got your name correct and haven't attributed too much to you that you did or didn't do. So does it seem like a decade on?
Yeah, that's true. It's a little bit more than a decade. Just improves the way we talk about it. I'm a neurologist, stroke neurologist, but I also have a background in medical decision science and epidemiology, which helped me a lot when we started the trial and revised the trial and the way we did it. And I think it's very important to mention it was not a trial by one person. It was a large group effort. We were with 6 principal investigators from 3 large centers in the Netherlands, and we took care to represent neurologists, which take care of the stroke patients usually in the Netherlands, not internal medicine or whatever, and interventional radiology do interventions in all parts of the body. And those were the guys that we were leading the trial. And we were quite skeptical about the potential results, actually. We were very modest about what we thought we could achieve, but well, it turned out differently. That's true.
That's really good, because from an outsider sometimes, and some of the research I've been on the fringe with, you often think actually, everybody's made their mind up. This is a foregone conclusion about the outcome. It's a bit of...
Actually, I was the one who was most skeptical of all. I said,
think that's really healthy.
How can such a treatment, like going with the catheter into the body through the arteries up to the brain and getting lesion out of the artery, takes a lot of time, half an hour. Sometimes you suffer the stroke for a few hours already. And we know that brain cells, if they don't get glucose and oxygen, die within minutes. So what are we doing? And so I thought we should do this trial just to find out if it might work for somebody, but it was much better than we thought. Much better.
Well, I think that's the perfect advert for why research is so important.
Yes, exactly.
You just don't know. And today in the UK, we've just had the announcement that it's for search. So it's phenomenal, and it's good. I think it's really healthy to be skeptical. I think that's what you get. If the left arm is to spasticity now and again, and if I think about certain things, the arm moves. I have to watch it on the bike.
Yes,
it's quite hilarious. What surprised you most, Diederik, about the response when it was published?
It was, I think we got a massive. What also surprised me was when I can tell that now, when we submitted the paper describing the results and showing that we had 30 to 40% more patients recovering than with medical treatment alone, which is a very huge effect. We submitted the paper in October to the journal, and it was published in January the next year, 3 months. So that was terrible. And afterwards, I understood that they waited for the other trials to submit their paper so they could publish 3 or 4 papers about different trials, all showing the effect of the treatment. So that would be very convincing and really changing medical practice in many countries. So that's wonderful.
It's something to be applauded for. I know you said it's a team effort, but the whole team's not here, so
Yeah.
I can only applaud you while you're here. But I think it's something to be applauded. Now, I've done my best to try and dig out figures worldwide for the amount of thrombectomies that have taken place on stroke patients, and
I can tell you what
you've got a
happened.
figure.
Yeah. What happened in the Netherlands that we prepare ourselves quite well, I think, because unlike in the US, for example, where they already did the treatment but didn't have sufficient evidence, and then were embarrassed by the results of the IMS3 trial, which was neutral, and they stopped doing the intervention. We did the other way, chairs of the guideline committee for the National Guideline Committee on Stroke. And I said, we have to put in that the thrombectomy treatment should only be done within the context of a trial, not outside, because otherwise we will be lost. We won't be able to do the trial and we won't get evidence, and it will be going on like the US. And so we did that. That was important point. So I think that was very important. And what happened afterwards is that when it was positive, it went very fast, and we could change the guidelines, and everybody wanted to do the intervention. We had discussions about which hospitals should do it, which won't, and that went very well, I think. And now we have about 8 or 10% of all stroke patients get the treatment, and we estimated that we should improve that and go to 15%, maybe 20%. Then we have everyone. And that's fortunate that trials after hours show that even patients with very large deficits or actions on the brain stem and patients getting in after 20 overall. The only patients that don't get benefit are the ones with the small infarctions in tiny arteries going further into the brain. The benefit is less and the risks of the treatment are too high, so we don't do that.
Right.
Yeah, but
and obviously that's something which is changes. The technology's changed, isn't it? The devices are getting much smaller.
Maybe in 10 years we do that also.
Yeah,
at this moment we shouldn't.
But at the moment, right.
Yeah, and it's also it's true that you can do the treatment within 20 hours, but it doesn't mean that the benefit is just as large. It's a selected group. So you should do it as fast and as early as possible.
So I'm a complete uneducated. I'm no clinical background whatsoever. I'm just unfortunate enough to have had a stroke. And so a lot of the guidance for different countries talk around being up to 24 hours and based on salvageable brain matter, which sounds really crude, but what does that really mean? What's the decision-making process for deciding whether it can be extended for 24 hours?
Yeah, what you need to do is to do a scan with perfusion imaging so that you can see how the blood flow in the brain is and which parts of the brain don't get anything at all are dead. That's important. But even if you don't do that, but just if the scan is okay, more or less, and you just do the treatment, that will be okay too. And you save lives. But it's only a tiny proportion of all patients. And and the benefit is much larger if you do it early. So give them in as fast as possible. It's important.
So you're more than likely to do more good than harm, even if it's longer. But obviously, sure, the quicker you do it, the better. Brain equals time. I was talking about numbers. Now, I had to rely on AI, unfortunately, to try and get me some numbers because I got lost down a rabbit hole of looking at different countries, and no one seems to present the data the same. So the estimate since 2015 went as high as 3 million people globally may have been through it. which it sort of blew my mind. And you're a fairly large country in Netherlands. If you think of if you put all your population out, this is how I was picturing it on a map, and then thought of that as a percentage. It's a phenomenal amount of people around the world that have benefited. Certainly since countries like China with population boom and them taking on the technology themselves and the treatments. So no, it's unbelievable the difference it's made. Now it's good and it's 24/7 in lots of places in the UK, but we're not consistent yet. And I think we've taken. I'm sure the decision makers would argue with me and say I'm wrong, but we've taken a long time to get our staffing right. And we've only had nearly 15 years to plan for the staffing. It's not a particular shock, but the staffing isn't quite there yet. But we have got what the GMC, the General Medical Council, call credentials now, so that other interventional radiologists can be trained up. So from cardiology into people moving into a different disciplines of sorts. How did you cope in the Netherlands with the staffing? Because it's fantastic that you get this evidence that, this is going to reduce lifelong disability. It's going to save lives. And to the politicians, that equals pound signs. Less disability is less benefits. It's people who are economically viable. There's less impact on their families. But you've got to have the people. And I guess, it's only a small pond worldwide. Everybody wants these people, the interventional radiologists, to come and do the work.
Yeah.
How did the Netherlands give up for that? Does that make sense?
Yeah, what we did was we said that every interventional radiologist should be able to do this. And most of them like to do it because it's not too different benefit to be gained, so you're a hero when you do it. So they like that. And
that's good.
And of course, the Netherlands are very well equipped with large centers that have the possibilities. And we immediately after the trial results, we had meetings with the policymakers and said, well, these and these centers should be able to do it and should do it. And we have a few neurologists that were trained as interventional neurologists, but mostly as radiologists. Sometimes
retraining's been the key.
Yeah. So we had sufficient people doing it. Yeah.
That's fabulous.
And very important, we also asked all the primary simple hospitals, the small hospitals, the primary stroke centers, to always do CT scan and CTA scan, CT perfusion if possible, and send their patients in immediately when they get someone with stroke and an occlusion that can be treated. They were trained for that, and they do that, and they know that if they send them in, they get them back. It's very important for them because they want to see their patients and they also want to treat them. And
so if someone presents at a non-stroke sort of centre, they get the diagnosis and then they're
immediately
shipped to the major.
Yeah.
Right.
And then they get the treatment and they go back to the primary stroke centre. They have to be certified as that. Primary stroke centre.
And that's really important because it's a model which they've tried to adopt here. And our job is still not a big country, but the geography is different. And it causes, and people have said to me when I've been involved in it, but just think of the benefits. But actually, it causes a great challenge to family members and loved ones when their patients are so far away if they're not repatriated back to their hospitals locally to where they live.
They should be sent back again. That's the point.
Because it has an impact on their rehab.
Actually, our intervention centers are not equipped to keep all the patients because they would be overloaded and wouldn't work. So that's okay. And what we also did was that we made a prediction model, two prediction models. One model just to predict treatment benefit, how much improvement, how much gain in quality of life you will get when you get the treatment. So that's very important for when you're a neurologist in a remote center and you have a patient that has to be transferred, then you can see with the model time on severity of stroke, etc., and you can predict the benefit they get. And if they only have improving, you might decide not to send them in because the trip to the center will be so long and lead to complications and then pneumonia and things like that. So that's a nice way of looking at it.
So that's fabulous. So your clinicians have got a tool which they can use.
Yeah. It's a very simple model. It can be used online. It's being used. And the other
is that
thing
being used in other countries? Sorry, Diederik. Are other countries adopted that? Because that sounds like a fantastically powerful tool.
Some do, but they've not integrated in their
right
usual care. Well, not that, but they use it for research mostly. But we use it really. And the other thing we did was we're evaluating that. That's another guy from our center, Bob Rosenberg. He devised a prediction model of treatment benefit. Depending on where you are, the likelihood, taking into account the likelihood of that you have a thrombectomy indication or not, is between you where you are and the primary stroke center and the intervention center. You might, and depending on the chances of recovery, you go to the primary stroke center or to the intervention center immediately and skip chances of recovery.
So it's more quality around the door to needle time.
Yeah, so it's driven by the expected benefit of the treatments you can get in each hospital. That's being evaluated at this moment. We're almost ready.
And we obviously, it's great that we've got some treatment. It's the next best thing. We've got a miracle for ischemic stroke at the moment, I'd say. It's the gold standard. But going back from that, we obviously don't want people to have strokes. What's the Netherlands' approach around stroke prevention? Is it awareness, or is there particular schemes that they focus on?
Yeah, we have the Dutch Heart Foundation, which we call Dutch Heart and Stroke Foundation, but they don't do that. And they help making guidelines, and we have a national guideline, and we have the friction is between the neurologist and the stroke therapeutes and the general practitioners. They have their own guidelines, and they're a bit more conservative. One thing they have is, I always like to mention that we say every patient that has a stroke within 24 hours should be in the stroke center immediately. And the GPs say, well, if you possibly have a stroke, you call, or spouse will call the alarm number, and then we ask, can you walk? And if it's later than 12 hours ago, and you can walk, you should walk to the GP's medical office, which is stupid and should be out of the guideline. It's terrible.
Now, I was going to share this with you. Because I've not introduced this at the beginning, but having just come back from I was lucky enough to have I'm a fairly chatty person, and I got chatting in some cafes. You have some great cafes, so spent them in Rotterdam. I've got to say it's Rotterdam, so people don't get the wrong idea. Those in Amsterdam cafes, because there's a different perception over here to cafes in the Netherlands than there is back home. So I was in coffee shops, I'll call it that, in Rotterdam, and one near to where I was staying, and I got friendly chatting with some people in there. And they were asking me what I did for a living. I explained I was retired now, used to work in healthcare in a management role. And I was shocked at it can't be a generalisation for the whole country, but at the view of Dutch healthcare. So I'm waxing lyrical about some of the advances, and I was talking about this. And their mind was a bit blown, saying, wow, there's millions of lives changed worldwide. And we said, why aren't you Dutch? I said, well, you can't all hear the same message at the same time. And they said, but our healthcare just really isn't very good. And I said, what do you mean it's not very good? Because there isn't an answer for everything. Doctors aren't magicians, which is the line I usually use. There's not a magic pill for everything. We've got to take some responsibility. And what they were complaining about was primary care. And you don't have to comment on this. And what I didn't hear them say were doctors were bad, their GPs, but they felt that it was so hard to get a GP appointment.
Yeah, that's true.
And what I was saying to I said, what I'm hearing is actually that things aren't over-medicalised. The way you explain it to me, actually, people are quite thoughtful about it. Because when they got the medical treatment, they were waxing lyrical about it. They were saying how good it was, but it was just so hard to access. Got me, I was quite surprised. That's all. You don't have to comment on it. It's just an observation.
Yeah, that's true. It's true what you say about the GPs. They have a difficult time. They're understaffed. But for stroke, you have many campaigns running saying, if you have a stroke, call 112 and you get that works.
So goodness around stroke.
Yeah.
Because I did ask them as well, what would you do if you spotted the signs of stroke? And then I got the usual, you look a bit young to have had a stroke. And so it was good to try and do some of that demystifying around ages. And then reminding them, there's a good reason the UK is called the Fat Man of Europe. It's not a coincidence.
But you posed the question in a cafe.
Yeah.
So maybe that's...
Yes.
That's not the right environment to do it.
No, it's not.
Yeah,
it was good to chat. Everybody was able to laugh at my attempt at Dutch.
Yeah.
But in terms of political, financial, or sort of scientific steps, to take it to the next stage, where it's easier to be adopted.
Yeah, the effect is so huge. You can't expect another huge effect like that on top of the thrombectomy, of course. I hope we can get into the more just to open them up.
Mm-hmm.
That's one thing, and probably will happen in a few years. The other thing is we've been looking at awareness again, and one peculiar thing was that the socioeconomic status of people makes difference.
Yeah,
it's obvious, but we checked that. We had a huge database of socioeconomic indices, and we could see that the treatment itself was just as effective for a poor guy as for a rich guy, but afterwards, the rehab, the outcome at 3 months is much better in the high socioeconomic levels. Same goes for alerting the ambulance system. Socioeconomic low-level people are slower in finding out they have a stroke, slower in alarming the ambulance
I think that
system.
reflects the UK as well. There's a trifecta of wealth and education and health.
Yes.
They do interlink.
Yeah, that's one thing. But about treatments, simple things as anticoagulants and antiplatelet treatments like aspirin and more modern antiplatelet agents probably will do something, and there will be more trials. One of the problems is most of the trials that are evaluating that are from China, and it's not certain that you can extrapolate those results to. That's one thing. The other thing is neuroprotectants. There are several very interesting agents, adverse effects. We have to be very careful about that. But I think there will be 1 or 2 agents within a few years that will help on top of when you can get the bloodstream flowing again. That's the point in time where you want to give an additional agent to protect the neurons and help them to function again. And that will happen.
From a predictive point, do you think there's a role for further research into biomarkers?
Yeah.
Just in terms of predicting what might be down the line for somebody.
Biomarkers. I think the most important biomarker, time and severity of the stroke. That's explains almost everything.
Right. And we've between I think it was Edinburgh and my being done over distance, yeah. Which is kind of ironic when they don't offer thrombectomy in Scotland, but they were able to do it at a distance to Miami from Scotland, which really is the irony. I don't think it's been lost on the Scottish people. Any sort of development in that in the robotic field, sort of remote telemedicine,
and we have some very interesting programs running that helps you interpreting the scans when you make a scan of a patient, and it helps the system running at this moment that alarms us when the CT scan sees thrombectomy.
Yeah, I'm familiar with that. Patient. It is quite fantastic, isn't it?
Yeah, that's good. Yeah, and it helps, but mostly in your experience, you don't need to be advised of the AI system. You just want the alert. That's important.
Yes, yeah. You really want to just use it as a decision aid rather than making a decision for you. I take it.
That's it. Yeah.
And just because I don't want to take too much more of your time up, just as a final one, I know I mentioned it before we spoke, was around mobile stroke units. This was something which Erasmus has looked at, I believe. But I think what most places around the world have seen, you're pushing into some high figures, into the millions often for an ambulance to be kitted out with a CT scanner and the challenges that brings with the extra weight, the extra staffing. And it can't be everywhere at once.
Yeah, that's the point. That's an important point. It's quite expensive, and we've been thinking about it and evaluating and thinking up a system that uses as less personnel, because that makes it very expensive also. It's called cost-effective analysis, looking at how would it perform in a urban area and around Rotterdam, which is quite remote. And it turns out that maybe, but it works better in urban environments than in rural areas, because then it's gone for a long time and you won't pick up a system with meet and greet, so that the normal ambulance goes to the urban area where the large hospital is, and the stroke tries to meet the ambulance, take over the patient, start thrombolysis, and then go to the thrombectomy center if needed.
Right, that sounds really interesting to hear that, because immediately you think of remote areas, but actually, if you've got a dense area, you can be seeing more people at a time.
You can do 20, 30 people in one day and save a few minutes per patient, but that would add more to the success of the treatment than one patient who is living very far away.
I know what I've read in the New England Medical Journal. It was talking about the research that's published there, but they saw over 90 days improved less long-term disability. So that I think the initial, as you say, it's where you put it.
Yeah, but that's
so
that
when everyone can benefit
at a per patient level, it works.
Yeah,
but you have to look at the community level. Yeah.
And you can't ignore the cost.
Yeah,
there's lots of important things, isn't there, that need to be served.
Yeah,
it's where searching the world of stroke, because I know when you Google you come up with 101 studies you're involved in. So I'm not sure where you get time to sleep or have any rest.
Yeah, actually, I'm partly retiring.
It's great.
So yes, that's good. So I work only 2-3 days a week on stroke and research. What I'm doing is I'm still have an advisory role in many studies, of course. Yes, that's true, and I like it very much. And the other thing is we have this one type of patient that is a younger woman, often of African descent, that has no atherosclerosis as the cause or no heart disease, but has a slight anomaly of the carotid artery in the neck, and that's probably genetic, and it's intrusion of the wall of the artery, and it causes embolism, thrombosis, embolism, and you don't know it, you miss it, and they're young women. For them, they should be saved from a current stroke. And we have been working on an AI program that helps you detect it. It's still under in research, and we know from experience in a few series in Amsterdam, Rotterdam, and also abroad in the US, that treatment is very easy with a stent or with endarterectomy operation on the artery, and then the chances that you get a recurrent stroke is zilch, none. So that's very interesting. It's a small proportion of all the stroke patients, only 2-3%, but we can save them. So
it's the impact on their lives and their families' lives. It's immeasurable.
Yeah, and of course we are involved in trials of neuroprotective agents, but that's for the distant future.
I said before, there's millions of people that have benefited from this. That's directly, but there's millions, for every one person, there's got to be at least 2, 3 people, 5 people that have benefited. So we are talking, it's millions upon millions. And one of those millions upon millions who've benefited is my friend's husband. And she wanted, and she'll be listening to this, and I'll name her Glenys. And she wanted to make sure that I passed on my thanks, but her husband's still alive because of you and the work of your team.
Okay, thank you.
So a huge thank you, and I'll hopefully be having a cup of tea with them in the distant future. But no, it is quite phenomenal. And so I've said for us, whilst I wasn't able to get a thrombectomy myself, it hasn't led me down this bitter road, because there's no guarantees. I don't know if it would have changed outcomes for me, and it's certainly, and I'm at pains to say it, none of the clinicians were at fault. They can only do what they're asked to do, and they weren't asked to deliver thrombectomy at that time. The hospital I went to, we're 10 years on, and we now have 24/7 thrombectomy at my local hospital. So I'm over the moon. Not for me, but for everybody who lives around here. We know that it's not my data; it's our health services data from when I worked. We know that we were losing 20 to 30 people a year needlessly from not being able to access this service. We reckon 300 to 400 people as well were living with lifelong disability as a result of not accessing it. So that's just in my little part of the world. So no, it's fantastic how it's changed. So I can't criticise our local care, and it's getting better. So it's getting better across the country, and it's just challenge. It's one of many challenges we've got, certainly around capacity in the UK with health service, but it's not something that's going away. You know, we know from stroke, you know, the classical older person, we know it's doing that on the chart, but certainly working age is still doing that. You know, I know there's lots of complex theories as to why, but that it's still a challenge for us. So Diederik, it's very good of you to spend time. I'm sorry I couldn't make it in person. I apologize for me.
It was a pleasure talking to you.
No, likewise. And the last sort of snippet which you gave us about the work which could save, you know, hopefully this 3 to 4% of strokes for these women.
Yeah.
I look forward to hearing about that. You know, it sounds fantastic. So thanks for your time today.
Okay.
And enjoy retirement when it fully comes to you.
Thank you.
Just keep riding the bike. That's my answer to everything.
Yeah, okay.
That's what I'll be doing after this now.
Yeah, you too.
Cheers. Right. Thank you.